Good afternoon, everyone. Dr. Kalpa, Senior Manager for Education, India Vision Institute. Welcome everyone here at Zoom platform and also those that are viewing this through Facebook Live to the second talk of India Vision Institute's Knowledge Series to commemorate February, the Low Vision Awareness Month. It is very important for us to update on the recent advancements in any eye care. So today's topic is advancements in low vision intervention for central and peripheral visual field loss. So we have eminent speakers for this topic. So let me give a short brief about our speakers. Our first speaker is Professor Monica Chaudhary. She is consultant optometrist and educator, founder of Learn Beyond Vision, ex-director of School of Health Sciences, Sushant University, retired optometrist and educator, AIMS, senior consultant of IGNOR, professor and HOD of optometry, Amity University, and ex-chairman of Optometry Council of India. Welcome, ma'am, and happy to have you with us here today. Our second speaker is Dr. Rakesh Roshan, who is the co-founder and CEO of Ocutech Limited, Oxford University Enterprise, and he also serves as a board of directors for it. Ocutech is an vision artificial intelligence company established in 2016 that has developed a portfolio of products that are transforming lives of partially sighted individuals. Under Dr. Rakesh's leadership, its first generation product in UK and European market for people living with peripheral visual field loss, and launched its second generation product in quarter 2 of 2021 for central vision loss. Having formed and raised finance over 20 Oxford University technology companies, Dr. Rakesh brings commercial experience, technical understanding, and global networks to Ocutech. He is founding partner of UK-China Enterprise Fund, established to support high potential UK companies. Prior to taking up charge, Dr. Roshan was a key member of management team at the prestigious Oxford University Innovation. He guided multidisciplinary teams to negotiate investment transactions and led the business development ventures in Asia. He holds a physics PhD and qualifications in entrepreneurial finance from the University of Oxford. His career in the enterprise world with Japanese electronics firm Sharp Corporation. He is named inventor on patents and technologies which have been integrated in products. Warm welcome from India Vision Institute, Dr. Rakesh Roshan. We have Dr. Sumit Grover, ophthalmologist, here with us, who will give us, will highlight us the ophthalmologist perspective in using these advancements in the low vision intervention. So we'll start the session now. We'll have Professor Monica start the session, followed by Dr. Rakesh Roshan and Dr. Sumit Grover, and then we will open the forum for questions. So any questions we here in the chat box or in the Q&A, and even those that are viewing through Facebook, you can also post your question. Happy to moderate that. Over to you, Professor Monica Chaudhary.
Thank you so much, Kalpa. Kalpa, you have to let my video be on. Thank you. My video is not coming in. Second, the share screen option has to be given.
Can you try now?
Okay.
Yes.
Thank you so much. And of course, we are typically like educators, and it's wonderful that you're conducting a low vision awareness. I think the very thought this IVI has brought in is very important, because here we are sitting and talking about advancements, and there are certain stages where a lot more awareness at the basic level also has to be built up between the eye care practitioners. And with my flow of presentation, not only moving on to what we were a few years back and now what we are advanced into, lot more technologies, lot more digitalization, and wonderful things that are coming up for the visually impaired. So please permit me to share my screen. Thank you. So, yes, we are here talking about the advancements, and we are specifically going to be mentioning how we differentiate the central and the peripheral field loss. So, it's a changing time, and I'm grateful again, IVI, for bringing this up. Um, we've always been talking about low vision, but what I feel the basic thing one has to understand is how much do you understand this visually impaired patient? We've always lived with 6 by 6, maybe probably good vision, and hence to understand what the quality or the type of vision this patient is undergoing is missing in most of the eye care practices. And because we do not understand this, sometimes the judgment of putting these devices onto the patient is not calculated properly. So, first thing that I would like to add here to begin with any eye exam, low vision is actually beyond our vision charts. We as professionals are being used to those 6 by 6, 6 by 60, 6 by 18s, and these typical terminologies in our clinics. We make our patients sit, and for us, like 6 by 24 is bad, 636 is bad, and 6 by 60. But a 6 by 60 to a 6 by 24 makes a life changer for the patients. A 3 by 60 to 6 by 60 is life changer for our patients, which we do not understand. And many of our times I have found our students talking, it only improves to n by 10. It doesn't go to n by 6, and hence the device becomes a useless thing. No, it's not that. For a patient, even n by 10 means a lot. So, the first basic message I'd like to give here is we move beyond this. We are used to this definition of low vision, and typically 6 by 18 best corrected or 10 degrees from the point of fixation. But what it also says is potentially able to use vision for the planning or execution of the task. And that's where I want to emphasize. It's many times 6 by 9 partial also with the field effect who is visually impaired or is not able to use his vision or execute the task. Four categories: moderate, slight, severe, profound is good to be understood by any time when you are doing your patient, because based on this, your whole concept of dealing with the patient, whether it is moving into what level of rehabilitation, what kind of needs you can cater to, of course, this broadly classifies, and I know all practitioners would be aware of it. A very important thing, very, very basic thing, but a mistake which most of the practitioners or the optometrists do. The word visual impairment is a broader umbrella which consists of low vision, where we have 6 by 60, 6 by 18 to 3 by 60, and then we move on to blind. By definition, 3 by 60 or less. It could be a total blind or a legal blind, which is less than 6 by 60. I mentioned this slide here because many times the terminology used is not proper. Whether we use the word blind or a low vision and then combined together, both of them fall under the category of visual impairment. The numbers are huge. The numbers are so huge, and we have very few practitioners who are actually practicing low vision. The other term is rehabilitation. Now, whenever we as eye care practitioners deal with the patient, we only talk about the clinic, the improvement, and the prescription of device. But we forget a very major role, which is the rehabilitation service for these partially sighted, to bring that the adaptive process to bring them back into independence. And the connect between the two have to be perfectly maintained. So, what does low vision totally mean? Number one, it means you enhance the residual sight. A patient has a particular amount of vision, the devices or whatever rehab or other assistive technologies that you use, you would just enhance that vision so that that residual vision makes them more independent and functional. And the second is principle of all these optical devices which we have used. So you have a spectacle prescription, all you have to do is magnify to the level that it falls into the category of the residual vision the patient has. The third step is most important: make them independent. Just do not think you've given the vision to the patient on the vision chart or a near vision chart, it ends up. The third step for a patient is making them independent. Important thing to begin with here is understanding contrast and glare for the patient. When we do the visual acuity exams, we are used to this dark black alphabets on a white chart. But the real life and the world is not this. Most of the low vision pathologies and patients, the contrast will go down, the glare is going to be a big problem. The patient is mostly associated with these things. Now, the 6 by 12 for that patient or a 6 by 20 for that patient would again be a blurred 6 by 24 because of the contrast or the glare being too bright. He's unable to perceive that. So again, I reinforce those quantity numbers have no meaning as far as we don't understand, if we do not understand the patient. And now let's look at the patients through various conditions. When I talk of various conditions, and if I'm talking about a patient's visual acuity, we make them sit on the chart and we record, but there is a big field of vision contribution into his independence and the kind of device or the prescription. So, quick thing to understand central and peripheral field loss. Of course, there is an overall blur also in this category, but we talk about these two major things. Whenever a low vision exam has to be done, I would say forget everything else, but don't miss on assessing the field defect of the patient. We do not need those Humphrey or automated perimetry reports. We do not need sophisticated equipments. A good confrontation will tell us about the peripheral field loss. All you need to go is from the fingers and finding out how far it can go. The other, just stand in front of the patient and ask what he can see, your face, your nose, or how much area can he see. That is very important for us to know and understand and manage our patient. The second is central field loss, macular degenerations and others, which where we have the central field loss gone. Now, both the pictures, I give a pause and I request all the audience to have a look into it. This one is a picture where the patient is maybe even good vision, 6 by 6 could be, but is tubular field. Imagine yourself looking through a finger or a tube, making yourself into 5 or 10 degrees of visual field. How can you move about? What will be your major disability? Your major disability is mobility. You're like tracking through this tube, and most of the patients may have one eye functional. And you're tracking through this tube, you have to scan the whole room, you can't see. So, I may be able to see this laptop even with this tubular field, or I can, but what happens to the sides around? What happens to the vision? I can bump into the objects. So, orientation and mobility is the major disability with peripheral field loss. The second thing is we're talking about central field loss patients. Depending upon the field loss, you see, periphery can be used. Patients get adapted to the periphery. But what is their major concern? Looking at the face, the whole face becomes dark. So these are the patients who keep complaining and telling you the social activities where they can't interact, somebody coming to them, they can't see the faces. The second thing is the reading. The near vision is totally based on this central vision. They are trying to hit around, and it's the major hit. Most of the time, if the requirements are near vision. So unless you have assessed with an Amsler chart or even with the field you can confrontation, unless you have assessed, I think the heading should begin with this only in a low vision exam before you start working on your devices, whether it was classified into a central or a peripheral field loss. So, whenever we assess a patient, we try to see the difficulty in managing day to day activities. It varies from a student whose activity is like studying, or a person who has a mobility issue or mobile phones, So, every day to day task, and we have to enter into the domain of that patient's life, understanding the age, the occupation. what would be the requirements, how would this patient need the life, and what would be the problems with his field defects. So most of the time when we come across, the patients are concerned about travel, the self care, being more independent, and handling reading, even like food, print, sign, kitchen. And above all, many of our elder patients, especially the macular degeneration, are looking at television, recognition of faces, and other things. So, these are few listed points where our patient has to be assessed and treated. The sequence, of course, each one of us is aware of. We start with visual acuity, refractions, contrast, and then we move on to the trials. A quick few run of the slides, what we had so far for years. We had these devices, which were the telescopes for distance and the filters for the distance vision enhancement. And some devices, of course, we've been seeing evolution in these telescopes, but not much. They're big, and I would say cosmetically less acceptable. However, we have evolved, and we'll come into some of the devices later with it. The near vision devices, spectacle magnifiers, hand magnifiers, stand magnifiers, and you had a limit to this optical prescription. You can't go up. I mean, practically, I've not been able to go beyond 6x or 8x. We had 16x for others also, but it's been not a useful kind of device. Optical devices, yes, but still a big support system to the patient who cannot see anything to be able to see anything. There were limitations, the patient's postures were a problem, and we cannot go beyond a certain limit. So we had so far these optical devices, we had these illuminations and non-optical devices like typoscopes, writing filters, and other things. But what's coming up? The technologies, the assistive technologies, and the advancements. In telescopes, as I said, yes, we have the Ocutech Bioptic telescope. I find it, I pictured it because I find it quite useful, of course, because it's cosmetically appealing and has a good optics, much acceptable to our patients. But these are the patients who are moderate, slight to moderate kind of visual impairment, and I have a reasonable good quality of field effect where we would, I might say, lesser field effect where we have been able to advise them. So the optical devices, lots of advantages, disadvantages. We've moved into portable video magnifiers here, of course. These are the portable devices. I'll put this on. Been trainings been done and very useful. You can go up to 40x, you can go up to 60x. So you have this kind of scanner system, and I think it's one prescription device which where you even don't have to be worrying much about the magnification calculations. Patients can enhance contrast. It has color moderations to be done to enhance contrast. A wonderful near vision reading device, I think, very practical for most of our patients. The lot more other devices specific to certain needs of students where you can have laptop, or most importantly, conversion from text to speech synthesizers, and this has evolved in time. So years back we used to have these expensive equipments where we put in the book and it reads out, but now even our smartphones are text to speech synthesizers. You have apps. We have had this picture from the internet, patient clicking up and reads out the menu, he can convert. So you see the visual impairment, a smartphone is a big low vision device. There are many apps which are supporting them also. Softwares are unlimited to help these visually impaired. We may not know all of them, but we need to refer our patient to the right rehabilitation center. There are many rehab centers where all these kind of trainings are provided and at much subsidized cost to our patients. Don't forget to supplement all your patients who have contrast issues with these filters. It really works. Whether I prescribe any device, I think prescribing these filters mean a lot. So now we come into the discussion about peripheral field loss. For years that I have been doing The peripheral field loss, we only had more of theoretical Fresnel prisms or the reverse telescopes and these kind of things. Practically, I've not been able to help my patient with those tubular fields at all so far, because these were not actually working well for our patients. There have been hardly any prescriptions that we have been doing, and a peripheral field loss patients, we've just given up. Central field loss patients, we again were giving up. If it was a large field loss patient, the device, whatever I want to try, these optical devices, vision won't improve, and we've left our patients again to it. So now what's the advancement? The advancement is these electronic glasses, which is the innovation in the world of low vision, which have come in. And one of these devices, of course, we have the peripheral field loss smart glasses, which are the crystal devices, which have been developed by the Oxide, and you'll hear a lot more about it next after my presentation. And the name Onyx for a central field loss. Of course, this picture is of the prototype. We have much advanced version, which Dr. Rakesh Roshan will show it to you. So I was part of this team, and I was fortunate to be part of this team in the trials that we had done few years back, and the launch was done. UK. I would say the patients have started taking a lot of advantage out of it, and the scientists have given us these wonderful devices. India already has that. It's the availability is here. We're now waiting for the practitioners to understand what it is. So, summing up again, understand your patients, individuals, whether it's an 80-year-old ARMD patient, what kind of field effect, what's his quality, what's his need. And the other end, you have these peripheral field loss patients. What's his need? What's his requirement? Don't forget to link all this up in your eye exam. It's just not like our routine normal visual examinations where you just as a thing, you keep writing up your case sheets. No. Sit with your patient, understand, and quick assessments move out of the clinic. In fact, many times the eye exam should be beyond your visual acuity charts, making them realize what they see out of the window, whether they see you, whether they see the attendant who's come along with them. These are few things, whether they can hold the book, whether they can see things on the table. And last, I am still into education, and we conduct several low vision courses. We've had quite a few of the practitioners. If any one of you is interested in learning further all about low vision, please contact me, and we can help you learn for the low vision these online courses. So that's one from my end, and I hand over. The details have not yet been shared. We have the best person here, Dr. Rakesh Roshan, who can make you understand about these devices much more than me. Thank you.
Thank you so much, Professor Monica Chaudhary. Over to you, Dr. Rakesh.
Yeah, thank you. How much time have I got, Kalpana?
20 minutes.
20 minutes. Okay, that's fine. So good morning, everybody, and good afternoon. So it's afternoon in India. And thanks, Kalpana, for inviting us and me in particular, and Monica for all the support that you have been providing. You are our guiding light and the inspiration that you have shown, because this whole area of low vision needs awareness. It needs three things: awareness, awareness, awareness generation at every level. And any effort made in that direction is absolutely important. Um, Let me, because I was planning not to present my slides or anything, just talk through, but I will give you some pointers of why it's important. If I can be allowed to present, Kalpana, that would be good.
Yes.
Thank you.
You can try.
Yeah, thank you very much. So yes, I will use these slides that I have got for reference point. However, I think as I said, this whole area of low vision is very interesting. And the reason it's very interesting is mainly because it's very large number of people who suffer from various type of low vision and sight losses in general. And if you look into this particular slides that I have here, it shows that there are 400 million and more than 400 million people worldwide who suffer from sight loss. And there are three major type of sight losses. And when we are talking about sight loss, it goes beyond that equity chart, as Professor Chaudhary Monica was suggesting, that of course, visual impairment has a massive big spectrum. And if you look into the visual impairment, the way I see this is that you have some kind of an issue with the eye, and that could be cataract or issues that can be fixed. So that's definitely, and myopia, etc., are also part of the visual impairment, where you can really address that with existing solutions. Then you have second part of that segment where people have severe to moderate visual impairment, which perhaps cannot be fixed with any interventions. So that's where majority of these conditions are. And the last one are when people lose complete vision, they are totally blind. They don't, they may have some light perception, but it's very much towards the very end of the vision. But I don't know if you're aware that only 10% of the people lose sight completely, but there are 90% people in that spectrum which you can help with various interventions, with various solutions. And one of the solutions that we are Oxford University company, we are developing is a digital solution, wearable technologies that addresses this central part of the visual impairment area. And if you look into visual impairment, people lose sight for various reasons. Of course, there is central vision loss, as it shows over here, my cursor. There are 200 million people who suffer from central vision loss. And the conditions that leads to central vision loss are Stargardt, macular degeneration, age-related. And, this is basically most of the people who are elderly, they suffer from this disease. And this population is growing rapidly. And I will show you in the next slide, because of the lifestyle we have, we are living longer. So, one of the data suggests that 1 in 3 people above the age of 80 suffer from central vision loss. It's a massive, and imagine the growing population that exists out there. There is a lot of opportunity to help number of people. And given that low vision is still not in the mainstream practice, a lot of work is required, a lot of mobilization is required, a lot of understanding needs to be created right from education to the practice level. Then the second type of vision loss is general field loss, and diabetic retinopathy is a very good example of that. Where people have patchy visions. You have parts of the field of view that is available to you, but the rest is blocked almost. You can't see through them properly. And the last one, as Monica says, 84 million people, where people suffer from glaucoma and retinitis pigmentosa. Monica very well described. It has a major personal impact and a lot of economic impact as well. So government around the world are looking into this very closely. A lot of attention is being paid on the basic research of addressing and understanding macular degeneration, etc. Today, 3 months ago, I was at one of the session here in the UK, where one of the quite a few of the leading ophthalmologists got together, and now they're using artificial intelligence to actually identify macular degeneration at a very early stage, so that provisions could be put in place for managing the disease, because these are very large number of people that actually end up with central vision loss, and it's kind of an epidemic which has got unnoticed at the moment. But I think that's why I'm so pleased that this particular representation or session has been arranged, because it is just a contribution to that wider activity that is required for increasing the significance of the low vision and how it impacts the economy and individual, and what could be done to provide solutions so that people can have a better quality of life and independence, of course. So this is the data that you see. It's growing rapidly. This is for AMD and macular degeneration, because, as I said, people are living longer. In the UK, I'll give you one data point. There are 1.8 million people who suffer from who are diagnosed with central vision loss. And every day, 200 people are added to this list. And out of those 1.8 million people, quite a few of them are at an early stage of the condition, but they progress very quickly into moderate and severe impairment, where there isn't any solution available other than the assistive digital solutions or magnifying glass or conventional solution people are using to just get on with their life. There are many other futuristic solution that is coming in place on top of the conventional solutions, which Monica very clearly outlined. And there are attempts being made to create invasive solutions. So at Moorfield Eye Hospital, there was recently a news in BBC. They are putting chips on the back of the retina and trying to communicate and provide some kind of a vision to severely impaired people who have no chance of even using the digital technologies. So this is a major uplift. There are gene therapy technology being used as well, but these are long-term solutions available. I'm sure they will move very fast, but I would see at least 10 years from now that will become a normal solution, protocol that would be adopted by the wider community. But what do we do now? And that's where we come in and trying to understand. So most of the devices that we build is done through proper research, and it's part of the innovation strategy that we have at Oxide. We have been in business for the last 6 years. Before that, the technology was incubated and researched within Oxford University's Eye Hospital. And at this point in time, what we do is we have spent a lot of time with customers, with patients, trying to understand where their, what is that they require so that the adoption of the technology is higher. And that is one of the challenges that we are trying to address at the moment, because yes, it sounds very nice and fantastic that we'll come up with a digital solution and a wearable solution that you can use, but it's not that straightforward. A lot of nuances that you need to consider while trying to build an ideal solution that customer will be able to adopt and use. So just to for totality, this is what you and I see. These are two fantastic, iconic buildings, landmarks. I know we can see this very clearly. But if you have central vision loss and peripheral vision loss, that's what you see. You'd have a big scotoma in the center, which allows you not to see very clearly what you're looking at. And this condition is quite, affects the individual's lifestyle, because imagine if you had this condition, you're not able to see the food on the plate, you're not able to see the phone in front of you. They use eccentric viewing to expand the text and see through the corner of your eye. You can't see your family members, a lot of issues with central vision loss. And similarly with peripheral vision loss, just imagine you can only see somebody's nose or part of the face who is sitting in front of you, and providing these solutions to them. So what we have developed is we have two products at the moment. One is the device for central vision loss, and there is another device for peripheral vision loss. I've not been able to demonstrate it, but there are a lot of videos for these on our website. So if you do get a chance, please visit our website. And on YouTube, we have our own Oxide channel. There are a lot of videos of customers, of care by people, practitioners, expanding on the benefits that the devices gives, and why these devices are one of the world's best devices in their own categories. And when you use our devices, especially for central vision loss, we have a product we call as Onyx. These are the few prototypes that I have at home. And then this is the Crystal 2, which is basically designed for central vision loss. I'll explain more about these devices in a minute, but that's what you see. So imagine from here, you start to see these, you get much bigger, much clarity of the objects that you're looking at. So it's quite important to understand, because when I'm talking to distributors who are going to sell these devices across the world at the moment, with Onyx, we have launched it in the UK. There are hundreds of people who are using these devices. We launched it in December, and we are about to launch this one, which is an advanced version of the first product we had, which was Crystal One, because Crystal One had a display size of 23 degrees, which is quite small for people who suffer from glaucoma, because their field of view isn't that narrow. That's around 25-degree field of view that they have. These devices give them 50, 60-degree field of view. So this will be launched towards the end of this year. This has already been clinical trial in various countries. But this is the one that we are selling at the moment, which is called as Onyx for central vision loss. Irrespective of what type of devices we have, it's quite important to understand from customers' point of view that what we have learned is the devices need to be having four important things in that, and that's where the adoption will increase. Number one, it needs to be very simple. I'll give you an example. People come up with questions. Oh, how many can you see YouTube video on your devices? Can you do internet? Is it Bluetooth connected? It is wireless. Customer don't require that. Customer require same things that are very simple. Customer require things that are intelligent enough, allows them to do what they're doing. It should be wearable. What means by wearability? It should be lightweight. It should not be cumbersome. It should not heat up. So there are a lot of other criteria that people look into for that. Having learned and done trials with number of hundreds of people, then we end up with a solution that we put on the market for customers to buy and use these devices. So many of the companies do get this wrong. They try to put in a lot of features in there. It does not matter. This particular device that you see is a prototype of Onyx, and this looks like this. So this is the picture of Onyx that you have over here, and this is the picture of the device Crystal that I showed you. So for central vision loss, this particular device is quite intelligent. These has artificial intelligence chips in there, which basically does automatic face detection, automatic object detection. But what it means, if you point this to a laptop, it will say on the screen that it's a laptop. If you point it to your mobile phone, it will say it's a mobile phone. So it's very, very intelligent. But what I realize is with the individuals, nobody uses these kind of features. What they want is something that is simple. They can operate with buttons. Imagine 85-year-old with shaking hands. They don't do this swipe. Because most of the AMD patient will have diabetes as well. The finger thumb, the tips would be not very sensitive. And imagine if you're giving them a device, they have to do fancy swipe, gesture operations. It doesn't work for them. And that's why when we build these devices, we have big, large buttons. And so that these buttons do one single operation. So it's simple for them to use. They know exactly, and they can do it with blind eyes, with closed eyes, they don't have to really look into what they're operating at. And that's why the devices that we have brought on the market is very attractive. We have a very large distribution deal in the US with a company that has been in the low vision for 43 years, and they're very excited about Onyx in general. And we have just started to sell it. It's not available in India at the moment. We are having discussions with some distributors who will sell across the country. Monica ma'am has a earlier version of the device. I'm in the process of sending her a proper final device so that she can continue to use it and try to understand how the devices fit in the Indian market. And see the benefit that it provides clinically to the customers. So overall, I think what is very important to understand is that the devices needs to have very high degree of adoption, and cost is extremely important point as well. So when you're talking about these three things, being simple, being intelligent enough, affordability is very, very important. When we were selling Crystal One, that device was for £4,000. it was very expensive. We did sell quite a few, and quite a few people benefited from it. But we realized that it was very, very expensive for people, and that's where, when we built Onyx, although it's still relatively expensive, we like to reduce the price, but this is at 1/3 of the cost of Crystal One. This device is being sold in the UK for £1,500, which is nearly 1.5 lakh Indian rupees in India. And this is very competitive. This is you know uh, the any other device in this segment are at least twice expensive, but you're getting 10 times better product, or a solution at almost half the price. And we will be launching Crystal at almost similar price. But it's not very easy to straight away reduce the prices, because a lot goes on into these devices. These devices have a camera, they have computer over here, and then you have displays very close to your eye. So what basic functionality these devices works on: camera takes the live images, and then the live images are processed by the computer, which is on the top, and the processed images is then presented onto the screen, and you can look through these eyepieces over here. So what happens is, and this is quite challenging task to do, because imagine, the way to explain this is, we are doing data processing of a live video images frame by frame. The kind of computational power that you require, the kind of the thermal management that you require, the battery management, because these are wearable devices. You can't put a very large battery in over here. You cannot do a state-of-the-art thermal management and make these devices bigger, because if you do that, the devices will become very big. And I'll show you, this is one of the devices that is sold by one of the companies in the Indian market and world around, which are VR-based devices. And ironically, this is sold to people with central vision loss. And by the very nature, these devices, if you look into what we have developed, is like tiny compared to what exists. And one of the problems with these devices, imagine in India, you have 45 degrees temperature, and if you put on these devices, it gets so hot inside. So it's very, very uncomfortable to wear. The second problem with these devices are, when people who have central vision loss, they have peripheral vision naturally existing. And as soon as you put this on, what you have done, you have blocked your natural vision. So it's kind of, I just find it quite interesting that, although it works for people with central vision loss, but it's very impractical solution that exists. And that's where we came up with our Onyx devices, where you put it on, your whole peripheral vision is all open, and you can still get on with your life, use your natural vision, plus benefit from getting images or information presented in the part of the eye that you can't see. So very excited with these two products that we have. Market is really very enthusiastic about it. We are working on doing a global distribution of these devices, so that everybody around the world can buy this, because it's a global problem that we are trying to address. And hopefully, I think soon we will have these devices in India. At the moment, there is a challenge that we are not able to produce to meet our demand. But we are working with our shareholders and investors to see whether we can scale up our production so that we can supply this around the world. So, as I said, there are many, many devices that exist, and this is the picture. There are many wearables out there. But one of the other important parameter for people with central vision loss, they would like to have big screen in front of the eye. For example, 70 degree plus field of view. And when you filter this criteria with everything that exists, only 2 or 3 solutions comes out. One is our device, Ocutech Onyx, and the others are VR-based devices, which are, basically, as I said, they have their own disadvantages. They're very big, bulky, and uncomfortable to wear. So that's where we are. I had a video just to show. I might do that, but sometimes video doesn't work very well online. But let me try to play this for you, see whether it works. And if it doesn't work, then I will stop. You can let me know via chat that the video wasn't.
I think your website and your other LinkedIn and other
Yeah,
pages
they
have
have the videos.
amazing
Yeah,
about the
yeah,
patient usage, and we can
yeah.
share
So
that link with
yeah,
our
yeah.
audience.
Absolutely, I will do that. So I will stop here, and I will be very happy to answer any questions. But in summary, these digital solutions or wearable solutions are the way forward for the future, because it's an all-rounder device. So what you can do with magnifying glass, you can do it with this. These are not that big enough. You can put it in your pocket, take it with you. You don't have to wear it all the time. You can put it through the lanyard and then use it as it's required. It does the same features that the device has is what you have in the advantages of a magnifying glass, advantage of a telescope. All is inbuilt in one solution now. So that's why you don't have to carry 5 different devices, and that is one of the challenge in this area of low vision, because you don't have the solution. A single solution cannot solve all the problems, and that's where we are trying to get to, so that people have to just buy one thing, and that can do that can cover all the scenarios that they are trying to use these technologies for. So yeah, it's a long way to go in terms of making advancement. So ongoing research and innovation is the way forward, but we're very pleased with what we have in hand at the moment. Thank you.
Thank you so much, Dr. Rakesh. Over to you, Dr. Sumit Group.
Yeah. So I think our
Yeah,
friend Dr. Sumit Grover would like everybody to know a little more about the ophthalmology perspective into all these devices.
yeah. Thank you so much. I hope I'm audible.
Yes.
Yeah, yeah. So after these very, knowledgeable and very thought-provoking presentation, I just want to make a crux, the crux out of all both the presentations from Professor Monica and Dr. Rakesh, is that the low vision rehabilitation is a kind of different thing from a typical eye examination. The priorities are different. The goal of the visual rehabilitation is to maximize the residual vision, and the cause of visual impairment and taking vision, to sharpest 6 by 6 is a secondary thing. But the primary thing, how we can maximize the visual residual vision function of the patient. And we have to, and there are few dictums. The dictums are: first is the patient with the disease, and second is the person himself. The patient with the disease, maybe like if I'm trained in glaucoma, I must say the patient presents with visual field loss, and there is increased latency in the dark adaptation time. They have increased latency in the dark adaptation time, and as well as the vision is dim. The patient complains difficulty in sometimes recognizing faces, etc. So we have to make the things tailor made for the patient. We have to see the person, their cognitive abilities, their knowledge, and how their overall health, if they can manage and use these tools efficiently. And other thing is that different tools for different tasks. Patients sometimes say feel that if they get one device, it can solve every problem. So as mentioned by and Professor Monica as well, the tools are different for different tasks. For peripheral vision losses, we have different devices like Crystal. For central vision losses, we have devices like Onyx. So these things have to be borne in mind. And from the discussion of Dr. Rakesh, he highlighted a very, very important point. The key thing, which is the need of the hour, is awareness, 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 and awareness of the patients, as well as awareness among the practitioners. So the low vision patients always, they are quite depressed. Depression is very common in them, and they think that this is the end of the world. and they feel that this is obtrusive, and non-affordable, and these devices are, unwelcoming if they use them in the society or the community. So these barriers have to be removed. Knowledge has to be imparted from the optometrist and the ophthalmologist. And the second, awareness needs to be, imparted in the fraternity as well. Like in the ophthalmologist fraternity, I must say that all the retina specialists, all people who are dealing with the ARMD, diabetic retinopathy, should counsel their patients in the coming to them in an advanced stage, to give them a hope that, this is not even the end. uh, but you can, we can go for the vision enhancement through these tools. And licensing of, the low vision specialists, I will call them LVS, low vision specialist, with the general ophthalmologist and specialist ophthalmologist is vital. I think this message I want to give to the uh, audience.
Thank you, Dr. Sumit Grover. We will now open the forum for questions. So attendees, any questions, please post here in the chat box or the Q&A. I have a question to all of you. Um, this is definitely a wonderful product. Oxide is a wonderful product with advanced technology like AI. Can you share the patient's perspective based on the clinical trial, or UK and other market people are from the clinician and patient's perspective? Can you share, highlight
Yeah.
us?
Yeah. So what happens is, as I said, I think we also are learning. To be frank, and patient are our best teachers. That's how I see this. So to answer your question is, Onyx is a very good device for people who have severe and moderate central vision loss. So when patient come in with such kind of condition, we do a proper clinical trial. So Monica has helped us to develop the protocol for the trials, and this is in mind to see what patient cannot do without the solution, and then what they can do with the solution. So in the clinical setting, as Monica very clearly articulated that, and that's where the awareness of low vision has to be promoted like anything. That we're not talking about changing the acuity and taking it very close to what the natural and vision. It was giving that edge, and that's what customers are looking at. If somebody has an improvement of 2 lines on the cell chart, that is a life-changing thing for that individual, right? So what we do in our clinical setting, we go through 3 scenarios or 4 scenarios maybe. One is reading, which is close and further. I don't suggest that Onyx is, as I said, is an all-rounder device. There are much better digital magnifiers that you can use, which is 60 times zoom in, and they can do a better job. But when customers, imagine, look at the customer, they can't carry 5 different devices with him, and that's where an overall champion device is very important, and that's where Oxide, Onyx, and Crystal fit in. And when you do the clinical trials, there are like help asking them to read in closer the text, and then at a distance of 10 meters or 5 meters, and then trying to ask them to identify objects around them, and that's what we help them to do. And then third one is recognizing faces. So these are the 4 areas that we look into, without and with. And what we find out, when we do the trials, 80% of the people benefit from the technology. And these are people who just walk in, we don't qualify those customers. So 80% of the people benefit from the technology. And then out of those 80%, 50 to 60% people have significant benefit. What do you mean significant benefit? They will have 2 to 3 line of improvement while they are reading. They are going to recognize faces very well. And if even see features, I have seen many customers, they have seen their they haven't seen their wife's face for 20 years or 18, 15 years. And they say, oh, you have grown older. I can see wrinkles in your face, your hairs are gray. And it's amazing, these kind of details are now visible to those individuals. And they can be more social, when, they don't have to wear it, because one of the problem with these devices are, Crystal is fantastic. It's getting in closer, but it uses a smaller screen. You don't need, but for these, it's still very big. People are cautious how they will look when they will, go in the social arena and have something silly wear. That's why we made this device, so that you don't have to wear it all the time. You can lift it, see something that you're interested in, and drop it back. But this is definitely better than this particular brick that's sold in the market. So yes, a lot of improvement is required, but customers benefit from these quite a lot. And as I say, significant benefit are around 52 to 60% people. And then I expect, if you put other constraints that customer may have, people would like to not use this in public, so they don't buy. So for some, that will be expensive. So I expect around 20 to 25% people will end up buying these devices, and that's what the data suggests at the moment. But they're benefiting
I'll
from it.
interrupt you here. I'll
After
interrupt
you.
you here to continue. In fact, it's the barrier in the mind of a practitioner. Usually, that's the experience I'll share. So, when we had a young person, a young male who benefited with this device, especially the crystal. Now, the father or the mother who are accompanying, or the caregivers, they would put this on, and they are normal people. Now, the normal person, even when I would use this, for me, it would be a pixelated image. So the understanding of what is going through the low vision patient is not understood by the attendant or the caregiver who decides whether this device should be purchased or not. Second thing I would say, it's an expensive device. No wonder. We are used to those few thousand hand magnifiers or other things. But look at the life changer it will make. People go in for such expensive treatments at times. If a one piece device can give back independence, life, the economic burden, I see no comparison. It's priceless. Looking at the face, as Dr. Rakesh was saying, you go through the videos of the patients when they had the first experience. In fact, I didn't know, I wanted to add that, but time constraint, these are the videos. Some of the patient who just had the trial and realized, it's like tears in their eyes. For us, we see the green color of the trees, we want to see the leaves, but for the patient who's visually impaired, even the green color of tree makes a difference. So that's all what we have to understand. Again, the mind block from being a practitioner as a normal person to what it means to the patient. There's a big gap which one has to understand.
Thank you, Professor Monica, and thank you, Dr. Rakesh. There is a question: how can oxide help low vision patients? If I have understood correctly, maybe it is like you have a visual field loss and it enhances the field. If they have an additional low vision also, how does this device help these patients?
So it's very, as I was showing one of my slides, that people who cannot see in the center, they have a big vision block. When you use Onyx, that majority of that missing picture becomes very clear to you. So you can read the, you can see somebody face in front of you. You can see the laptop while you're working. You can see the phone. So that improves the missing picture in the field of view in the center. Further information is provided, so that you are able to see more in that area of the part of the vision that you don't have. And similarly with peripheral vision loss, what you do is you have a very narrow field of view. It's called as tunnel vision. And you may have 5-degree field of view. When you use Crystal or Crystal 2, it will increase to 60-70-degree field of view. So in the general setting, if somebody is sitting in front of you, because people with peripheral vision loss, they scan their environment to see where the objects are. But with our glasses, you can see them all in one go. So you don't have to scan the environment to find out the objects or person that you're looking for. So yeah, so increasing, and there is also increase in acuity naturally, because you are looking into high contrast images very close to your eye, which basically helps them on top of the field of view expansion. People with peripheral vision loss, I have seen that their central vision, in the part of the vision that they left, that's in the center, the acuity is not a problem. Sometimes they use refractive index glasses that corrects their vision. But in central vision loss, the acuity is really, really low. And that's where the devices help them to increase the acuity as well.
Thank you, Dr. Rakesh. Dr. Sumit and Professor Monica, if you'd like to add anything.
Yeah, I think very well explained by Dr. Rakesh Roshan. But I want to remind Professor Monica, if you remember our patient, she was a house homemaker, and she came with her son, and she was very quite depressed that I can't even do activities of daily living. And when we did the oxide trial, she was overwhelmed with joy and had tears in her eyes. For us, the goal is 6 vision, going to shopping, but for her, patient specific goal was to just move around her home. Just how to do just a simple household task was a overall ambition of that patient, and we were able to fulfill that. So personally, I saw that patient, and she was very happy doing that. Her ambition, her goal was fulfilled. So it's not about the our objective, this thing that vision should be 6/6, ardent grating should show contrast sensitivity like this. It is very subjective thing, very patient specific thing. And as rightly said by Dr. Roshan, it can help around 80% of the patient, or I must say in my practice we have seen 60% of the patient, they were happy with the trials. And it's very patient specific, very, very, very subjective thing.
Thank you, Dr. Sumit. We don't have questions here. Any questions? We request you to email us at communications@indiavisioninstitute.org. I'm just putting our email ID here in the chat box. So any question, please share it with us, and we will forward that to Dr. Rakesh, Professor Monica, and Dr. Sumit Grover for their inputs. So on behalf of India Vision Institute, thank you so much, Dr. Rakesh Roshan, Professor Monica, and Dr. Sumit Grover for joining us and enlightening your expertise on advancements in low vision intervention for central and peripheral visual field loss, and also sharing us information on this advanced AI device, the Oxide. It's definitely an amazing product, and we are excited about it. And thank you everyone for joining us here today. This webinar will also be available in IVI's Facebook page, and this can be accessed anytime. Thank you all. And our next knowledge series panel discussion is on 28th February. So stay tuned to IVI's social media platform for further details of the upcoming sessions. Thank you, Dr. Rakesh Roshan, Professor Monica, and Dr. Sumit Grover for joining us.
Thank you.
Thank you for having me.
Thank you so much, Kalpa.
Thank you all.
IVI. And I think, yes, there is a lot more to know about these devices and technologies, which is, we welcome anybody who wants further knowledge on it. Thank you.
Thank you. Thank you all. Have a nice day.
Thank you.